So welcome. Thank you all for being here this morning. My name is Sherry Williams. I'm the Chief of Operations for a nonprofit telehealth organization in Blackshear, Georgia, not Lake Blackshear, over near the Okefenokee Swamp. And I am delighted to be here today to serve as a moderator for this panel. You're going to hear from some extremely accomplished people who are living and breathing the telehealth space every day. So we've got 40 minutes, which is a very short amount of time to hear all these great things. So with that, I'm just going to go ahead and introduce our panelists. We'll start on the end with Junior Harewood. Junior is the CEO for the Georgia and Alabama markets with United Healthcare. Claudia Douglas is a principal with PricewaterhouseCoopers, and Dalton Divakaran is the director and industry advisor for global healthcare at Salesforce. So as we were thinking about the logistics of the panel this morning, we were trying to figure out what's the best order of topics. And I feel really compelled to tell you an interesting story that Dalton was talking about from the very beginnings of COVID. We talk about telehealth is the future of healthcare and the future's in our hands. Our hands are open and it's already there, right? Now that we have it, what do we do with it to make it meaningful? And I just want Dalton to talk about the gentleman that you met in the very early days of COVID, and how did digital healthcare really transform and impact his life?
Thanks, Sherry. It's good to be with all of you. What a packed house here. So privileged to be here. Again, last 16 years being in healthcare technology. Prior to that, I was a nurse. Today, I'm part of a Salesforce advisory team for our global healthcare strategy and innovation. And part of it, when COVID hit India really bad in the second wave, it was really bad. And a lot of the resources were going to the major cities and the big organizations, and the villages or the rural areas were so neglected. So with the help of a nonprofit, we gathered a group of people, and we launched a network for volunteers of physicians and nurses across India, and then we launched, which ran in the rural part of India. What we did is we stood up Salesforce Health Cloud along with devices, which the doctors could hear their heart sounds, lung sounds, do ear exams, mouth exams, all virtually. And it was a phenomenal experience when I went down to witness all that was happening. What strikes so hard at me is just the sheer look of an elderly gentleman who just was marveled at all the technology that's happening. And when I inquired, it was his very first time that he was seeing a doctor. And I was like, wow, this is something that can give hope to a lot of people across the globe. And just to add to that, other projects around the globe, another example is working with a leading, actually a pioneer of palliative care in Spain. They just launched their pediatric palliative care unit a couple years ago. Then when COVID hit, they had no other hope but then go virtual and digital. And they stood up an entire pediatric palliative care across the nation where, it just opened up access to a lot of kids and their families. And it was one of the hardest things to go see and lead their project, because the kids, when they go through that, it's just so hard to witness. But what it is doing, it's bringing hope. What it's doing is letting families stay at their home where they need to stay, right? And during those last days that they have with their precious loved ones, it was a phenomenal thing to witness. But the efficiency of the system to dispatch ambulances and to find who is the nearest triage team available to go cater to them, that was all phenomenal. So virtual care, technology is providing an avenue to provide hope, and I think that's the future.
Thank you. So I talked to several of you this morning as we were coming in and standing in line to get our badges, and we were talking about the beginning of COVID. So we always talk like pre-COVID and post-COVID, and everything in between has just kind of been a blur up until now. So sometimes I'm like, did this happen? When did this happen? But we were talking about the very early days of the pandemic. Our company has been doing telehealth in Georgia since the early 2000s, and up until the pandemic, maybe like the day before the pandemic, it was more of, come on, you really need to offer digital healthcare solutions to your patients. There are patients who are living in your communities who don't have transportation to drive 2 miles to your office. They can't get there no matter what. So what would happen if you integrated telehealth and then wow, the pandemic hit and everybody suddenly loved telehealth. And it It was nuts. For months, I don't think the phone ever stopped ringing with healthcare systems and providers desperate to find ways to connect with their patients. So, COVID was definitely not a good thing, but in terms of long-term looking at healthcare and looking at new and easier ways for patients to have access, I think that was a good byproduct of the pandemic. So we saw lots of different flavors of telehealth coming out. Remote patient monitoring became a big thing. Remote therapeutic monitoring, traditional telehealth, direct-to-consumer telehealth, just all kinds of flavors of digital technology started coming out. When Claudia and I were talking and prepping for today, she used the term hybrid care. And I think that's exactly what we're experiencing. If you look at the various health systems and who are using telehealth and who are using remote patient monitoring, there's always that aspect of technology combined with that non-technology of traditional visits, patients coming into the office. So it truly has turned into a hybrid care model. And Claudia at Price Waterhouse has been working on a very interesting project called Hospital at Home. So as we were talking about this, it's easy to follow that patient journey and why the hospital at home model makes a lot of sense. So from a strategic standpoint, Claudia, what have you been doing in that area and what kind of successes have you seen?
Yeah, thanks, Sherry. So it's been very interesting, as you said, when COVID popped. I had done virtual care work, primarily on the West Coast of the U.S., where we see more integrated delivery networks. The payment of care and the provision of care are married, and it can be done, and it is done. It has been done for many years. And so the beautiful thing was we did have experience in this when COVID happened, and we were able to help a lot with different patient journeys, the strategy around it. Often these areas were undercapitalized from a technology standpoint or even from an operational standpoint. So when this popped, we worked a lot on strategy. As Dalton was saying earlier, we worked a lot on operational transformation. And one of the pieces, as we all know, kind of this moniker hospital at home came out. And I would say, that was how it was done 100 years ago, right? Marcus Welby came to your house, and here we are back in that space. And it's a little bit different now because we have technology we never had before that we could use. So working with different specialties, one of the things, of course, we've seen before COVID happened, 5% of primary care and about 6% of behavioral health was delivered virtually. And when we all saw it explode during COVID, right? Behavioral health, for many obvious reasons, often you don't have to physically touch a patient. There have also been many studies, I'm sure you all have seen them, where sometimes a patient is more willing or a consumer is more willing to tell you over video things that they feel, if they feel depressed or suicidal, than in the room with you. It somehow seems more safe for them to tell the computer or tell the telephone. So we've seen that explode. It was 60% during that time frame. But now we're seeing it normalize at about 15 to 18%, depending on the specialty. Of course, behavioral health is high up there. Primary care, diseases like I have a thyroid condition, endocrinology, so most of that can be done virtually. And what I love about that, the word hybrid care, is, we started with telehealth, then we kind of pivoted to virtual health, and now I see it as a hybrid model. So even in my own patient journey, I see my GYN doctor once a year, but I also have check-ins with her for my meds, and they're all virtual. And we can do things like labs to the house or labs closer. We can do imaging in different ways, mobile vans and different pieces. So in development of this, what I'll call hospital at home, but actually I will say most of my clients are pivoting away from that. And having been my background is I've been in healthcare for 28 years, and I'm not a typical consultant. I've spent half my career in industry. So I was a chief operating officer for 8 years. I was a strategy leader for 2 different health systems for about 5 years. And I would say I kind of come at it thinking about the safety and security in this, because when this popped, how are we going to keep people safe too, right? Like, what really should we do virtually, and what's safe to do virtually, and what do we really need to touch, who needs to be touched? And I would say one of the big pieces with the hospital at home program is a lot of clinicians immediately kind of buck up. They say, ooh, if this person, because we all know whoever's in the hospital now is really sick. It's not 20 years ago. And so if you're in the hospital now, you're pretty darn sick. And if I'm going to put a patient in their home with remote patient monitoring and with protocols, that remote patient monitoring better work and not have any blips. And there better be somebody within 15 minutes able to help that patient. And so we've kind of pivoted to talking a little bit more about hybrid care or connected care at home, just to make sure that transition's better and make sure the acuity level of the patient is appropriate. And working through that, so I'm actually kind of pivoting away from the hospital at home term for that reason.
Thank you. So Junior, United Health has really invested heavily in the behavioral health space. So I'm a social worker. I did direct client care for a number of years in a very small farming community in rural South Georgia. And connecting patients to psychiatric care was always difficult. So from a therapy standpoint as a social worker, I could only go so far in the care of my client, and then I needed that medical partner to come in, and it was very, very difficult for us to find that care in rural areas. I was looking at some statistics, and it really depends on who you Google, how you Google, what statistic is going to come up. But I think one common thing, irregardless of where you're looking, is the fact that behavioral health, mental health is always, if you look at bar charts, I mean, it is this high and everything else is, tiny. So the Kaiser Family Foundation did a little study, and they determined that pre-pandemic telehealth, in general, accounted for between 1% and 5% of overall care, just depending on where you looked. At the height of the pandemic, from behavioral health and substance abuse, it was above 40%. We took a look, this was like a month or two ago, and I think the stats are still around 36% in that behavioral health substance use space. So we can see very evidently with the numbers, the claims data, that behavioral health and telehealth virtual care definitely go hand in hand. It is a very easy way for people to connect with providers. Claudia said it very well. Sometimes it's easier to talk about touchy subjects, things that you're uncomfortable with when you're talking to a computer rather than when you're in the room with a living, breathing other human being. So Junior, what role is United Healthcare playing in the behavioral health space, and what strategies are being implemented to ensure that patients are able to access telehealth for their behavioral health and mental health needs?
Yeah, thank you very much, Sherry. I appreciate that. So United Healthcare, United Health Group, the kind of parent organization, has done a lot to try to fill in this gap in the behavioral health space. And we've made a number of investments internally in kind of creating the platform by which we're able to kind of deliver some of that virtual care. And that's kind of built out through a network with partnerships that we have for about, call it 67,000 providers across the country. But we're a massive organization that touches multiple different aspects of the healthcare system. And there's a recognition that there are entities and organizations that specialize in this space. And if we're kind of living our mission to help people live healthier lives and help the health system work better for everyone, it was incumbent on us to make investments in some of these startup organizations, companies and organizations that are very nimble and that are much more nimble than we can. So there's a number of different investments that we've made with multiple different organizations like Able2, Sanvello, Mindstrong, which they have different niches that they've been able to touch. And the investments that we've made, were around entities that address, what we see as barriers to behavioral health care. Some of those barriers is, one, it's for a lot of people, it's a lot more difficult to diagnose or self-diagnose the condition they have from a behavioral health space. My daughter can tell me that her leg hurts, right, very easily. But a person can't, a full adult, you really can't decipher if it's depression they're dealing with, or is it bipolar, or it's other conditions. So that's a barrier that folks have. Another barrier that you see is the stigma. We already talked about that, the stigma of having a behavioral health condition. And that keeps folks from getting the care that they actually need. There's also the convenience. There's a lot of, we talked about this, Sherry, there's a lot of clinicians out there who either have full panels or are no longer practicing and stay in the academics. So that access to care, especially in the rural markets, does not exist. And then you have the cost. Oftentimes when folks are stretched for cash, if it's between paying for a medical service that handles their physical condition versus behavioral health, they're more likely to address that physical condition. And then the last thing I'll mention is around frankly, the shortage of providers, right? So, these entities that I talked about that we've made investments in have addressed each one of these barriers, or attempting to address a lot of these barriers. You have, what I'll call that low acuity, where you have apps that are able to do some of that self-care, mindfulness, stress management, that kind of thing. Then you have that, I'd call that moderate, where you actually have access to licensed physicians that you can talk to. And then you have, we talked about hybrid, which is, I think just a great way to kind of describe this digital transformation, where folks may go to an outpatient facility for medication treatments. They may end up in an inpatient setting, but once they leave those settings, they still have that virtual care, that access to that clinical, that licensed counselor or licensed clinician to be able to kind of continue with that follow-up care. So we take a holistic approach, because even as we stand today, with the multiple different platforms that exist, the apps that exist, there's still not enough clinicians out there to meet the need, and the need that's going to continue to happen. So that's why we take a holistic approach. We know we can't do it by ourselves, so if we can invest in other entities to help advance this, is the approach that we decided to take.
Thank you. So it's easy and it's kind of fun to talk about patients in crisis and how digital technologies came in to save the day. That's kind of the sexy side of digital healthcare, right? It's fun to talk about. But there's another side of digital technologies using in healthcare where we're addressing patients from a prevention standpoint. So what would happen if we were able to take these same technologies and put in front of patients who are maybe on the verge of developing a chronic condition, or a patient that we know is maybe a frequent flyer into the ER just because they needed their blood pressure medication refilled and that was the only way they could get to it. What if we were able to take that patient and kind of put a digital bubble around them and really take care of those needs before they became acute and emergent? So Junior, United Healthcare, y'all have implemented lots of different programs in this regard. Yep. We spoke specifically about a program that you guys have implemented around patients who are pre-diabetic. Yeah. And I love this because this kind of spoke to my heart. Rather than calling it a diabetic program, they called it a weight loss program. And I'm like, okay, I'm going to sign up for that. That speaks to me. That's where I can sign up. So I think as we're implementing these things, being able to talk about it in a way that patients can relate, because why would you want to track? Why would I want to wear this thing on my wrist? I'm just a pre-diabetic. But if you tell me I'm going to lose some weight, okay, let me sign up. Give me that pen right now. So Junior, talk about what you guys are doing at United Healthcare.
Yeah, sure. It's interesting that that kind of that change in verbiage increases folks' intentions on participating in the program. Because it's hard for people to admit that they have a disease, and then once they do that mission, do they want to now take action on it? But if you talk about weight loss, that's a different ballgame. Because when you think about pre-diabetes and the dynamics that come along with that, and how it's had such an impact on our country, it's pretty staggering. I looked at this stat a little while ago, and it's shocking to me. We have approximately over 86 million people in this country living with pre-diabetes. All right, so to put that in perspective, we have more people with pre-diabetes than the entire population of Germany. All right, I'll say that one more time. I'll bring it, since we're talking about the South here. If you took the populations of North Carolina, South Carolina, Georgia, and Alabama, it is still less than the amount of people that we have in this country with diabetes, with pre-diabetes. So how do we address these items, right? It takes a collaboration, and one of the things that as we talked about, Sherry, is some of the digital things that we've done. So we've created a program that was kind of based on losing weight. Because if you lose a certain percentage of your weight, you reduce the possibility of going from prediabetes into diabetes. And it starts off with a quick health assessment that you do online, and that goes to a coach. And that coach sets up a call with you at any time that works for you. So if you're an early morning riser and you want to have a call at 5 o'clock before you kind of get your day going, or if you're a late person and you want to have a conversation at 10 p.m., that coach is there for you to have that dialogue and try to set the stage of what it is that you would like to try to accomplish. Then from there, they put you within a group. So now you have that support of other people who are trying to meet the same goals that you have. And again, some groups like to meet during lunchtime, some groups like to meet at 7 p.m., some groups like to meet 5 o'clock in the morning. They find those groups that have similar likes to you, and also that time period that works for you as well. And then from there, you start to work together about the different things that you can do to kind of manage your weight. And it's not a kind of a quick fad type of approach where they're trying to lose a bunch of weight in a short period of time. It's attempting to kind of change your lifestyle, right? So this program is an over a year-long program that exists, and it's looking for incremental steps that you do. So not necessarily change the way you're eating or stop eating carbs or stop going with a paleo diet or anything like that. It's just doing things that you have today and making some modifications. I'll give one quick example. It doesn't tell you to not eat cookies. But what you can do is when you rearrange your pantry, make sure the cookies are in a place that are a little bit more difficult to get to. Right? So don't put it in the line of eyesight so every time you open it up, you have it out there. Or in my household, the cookies are right on the island. You put it in the pantry, so you have to be actually walking by. Because there have been many times, especially during the pandemic, when you're kind of just doing your work there and the cookies there and you're just kind of just letting it go. So, talking about just little things like that. It also has a piece of it where it's this year-long series that you're watching, and you're seeing different stars and folks who are talking about things that they're doing, and it kind of creates almost like this reality TV show that you want to see the next series. So there's an entertainment value that comes along with that. And then as you progress through the program, in week 4 or week 5, if you made it that far, you get a gift. You get this huge box that comes to your home with a blender and stretchy bands. You got you have a weight scale, you have food scales, you have all these different things that now kind of helps you to kind of incentivize you to get to that next class. And that next class is about what kind of smoothies you can make. So now you can do the smoothies with the blender that you just received. As you continue to progress, you can have your activity tracker attached to the application as well. You can give access to your coach if you like or not. You have the Bluetooth enabled aspect of the scale. So it's really digitized in that aspect and makes it specific to you at times that are necessary for you. And what we've seen is the average weight loss over a year period of time is about 10 pounds. So it's been a phenomenal program. And the way we've kind of designed it is that for employers who purchased a program, they do not have to pay anything until we've seen someone who's been engaged and have met that first kind of 4-week threshold. And then there's this 6-week threshold, and that's when they make those payments. So it's a pay-per-performance type of offering. So again, it's a pre-diabetic program disguised. It's a weight loss program disguised as a pre-diabetic program. And we're always trying to find different ways to kind of engage folks, and that's been a really good program for us. So hopefully I didn't go too long there.
And I swear, Junior, you're peeking into my kitchen. Stop it. I like
And
my
my
cookies
pantry.
on the counter. So we started this panel about 10 to 15 minutes behind, so unless someone tells us we need to wrap it up at 9:10, we're going to continue going. So if Mark or Russ is here and you need us to hush, if you can just somebody give me a signal. So we're going to keep talking. Claudia and Dalton, I know that the remote patient monitoring aspect of care is something that you both have been working in. So Claudia, I'm going to start with you, and Dalton, have you follow up with your experience in that area?
Yeah, sure. So I'm going to actually tie into something Junior was saying earlier. when we talked about the behavioral health piece, one of my clients in the Northeast, they serve a very substantial social determinants of health population. And they were seeing for behavioral health about 50% no-show rates. It was difficult for people to leave work, take a bus, whatever that, get childcare to get in to see their provider. So when they were able to, with the waivers, do the visit on the phone, on their mobile phone, be on video or not be on video, they went from 50% no-show rates to 0. So that's just more piece that just shows that we should be continuing to do this, whether or not, I know later you're going to talk a little bit about the waivers, and I know everybody's interested in what's going to happen from a regulatory front. I think doing the right thing is doing the right thing, and we need to figure it out. And whether that's, owning more and connecting more and having more JVs to own the payment with the provision of care, or however that is, working with our local legislators and lobbyists, but making sure that this doesn't go away just because, payment or different regulations could change. So trying to impact that. One of the other pieces I think is really important in this chronic condition monitoring pieces, like you were just talking about, this pre-diabetes piece. So obviously, we've got CHF, we have COPD, we have diabetes, we've got a lot of chronic things that go on. People are living chronically with cancer. And so how are we going to make sure we're anticipating this? I have a really cool project that actually Dalton and I were talking last night. We both work a lot in international health, which I think makes me better at domestic health, because there's so much to be learned internationally and vice versa. And I have a client that's challenged us to extend healthy life by 10 years for their population. Healthy life, not just life, but healthy life. How are we going to do this? And it's all going to be through data and analytics and monitoring. And it's going to be, through your smartwatch. It's going to be through, at some point, we're going to have like in the hospital, you have monitors. You can see if people are moving, if they're going to get a pressure ulcer or a bed sore. We can have that at home at some point. Your smart fridge. I've seen some of these Samsung or these different fridges that are going to tell us, oh, by the way, Sherry and Claudia that are on that weight loss program.
Stay out of my kitchen, Claudia.
Maybe you don't want to take that little, that extra thing of ice cream, or are you sure are you sure you're going to have that other glass of wine? Do you really want to do that? So I think through all this monitoring, right, we're going to have a Cambrian explosion of data. One of my best friends is Dr. Rob Fassett, and he is not only a data scientist, but an amazing primary care physician. And he works with us and talks about this Cambrian explosion of data that's going to come. And within this, we are going to have to parse that. We don't want too many alerts, right? We already have providers have tons of alert fatigue. So how are we going to not over-alert and over-alert the patient? There's so much through AI we can be doing just to nudge that patient. We can be handling so many pre-diabetic patients with just that, without even the provider touching them. I don't know how you all feel, but so much of this is behavior modification, and how do you get to the heart of the patient, and what's going to make me change might be a little bit different than Sherry or Dalton or Junior, right? And so how do we figure that out and get their head? I know Livongo's done a lot with diabetes, and they've done some amazing things. How do we get in that person's head? And it always makes me think about, in this monitoring piece, I always think about the ads where you see the patient or the person later in life that has had multiple facial surgeries because they were a smoker or a trach or different things, and wow, that could be me, or the impact of, I could lose my toes or my foot if I'm diabetic, right? And tying that then to, in my 20s, when I've run, and this is me, I had a PCL transplant at 28, maybe I wasn't as active anymore, or I slowed down a little bit too much once I was a little bit older. Getting those nudges and reminding me, hey, that's okay, keep doing it. That's what's going to impact me and keep from that horrible event at 60 or 70 when you have a stroke, right? It's the stuff you're doing in your 20s, your 30s, your 40s. You start to travel, you're sitting on the plane too much, getting active. It's those kind of nudges and the things that's how we're going to improve population health through all this monitoring. And it doesn't have to be super expensive. Dalton and I were talking about one of these remote patient monitoring kits, and you should talk about that one in a second. I've used it as in my own market with my own provider, but he's used it internationally too. And it can be at different levels. Like, can be easy, and we can make it a little bit more high tech and complex. But as long as the patient can adopt it, or the consumer, or the caregiver family, in these hospital at home programs, a lot of it has to do with the family and what are they going to be able to do, and how much can they take on. I think we always have to make sure we keep the KISS principle. Keep it simple, stupid. Like, keep it as simple as we possibly can, because when it gets too complex, patients and consumers won't use it.
So we've just gotten the evil wrap it up sign. Okay. So I'm going to turn it to Dalton to close us out. But I will mention to you guys, just as kind of something, a follow-up action item for you, if you are in the digital health space, and hopefully you are all in the digital health space, and if not, you're getting into that space, there are regulations that are changing at just record speed. CMS proposed their upcoming changes. I think if the hearings haven't happened yet, they're happening soon. Those changes will go into effect on January 1. Once the changes go into effect, everyone has roughly 5 months-ish to apply for waivers, to make sure they're in line with what's going on. I'm not going to try to recite all the changes in that, but please take a look at CMS and make sure you're aware of those changes. And Dalton, just to wrap us up, give us a food for thought that we can walk away with today.
Sure.
Evil sign, they've cut our sound off.
At Salesforce, what we do with our customers, we innovate with our customers to orchestrate care, right? So that means care anywhere. And it actually covers the entire spectrum, what Junior and Claudia were saying, from prevention to acute to post-acute, to managing chronic care, to managing the programs, the incentives for behavior change as well, right? So a couple of things, even for RPM, CCM, medication therapy, it's all here to stay and drive value-based care and pay for performance rather than fee for service. And it's all going to drive us to value-based care. And what we do with our customers is innovate in that space across the spectrum, right? For just an example, RPM is often conducted in isolation. It needs an integrated approach, because if there is an abnormal reading and you can't schedule an appointment with the physician within the same system and have to wait another 30, 40 minutes on phone calls, that's not really going to help. And I just want to close with one last statement. Patient engagement doesn't really mean that the patient experience has been great through that engagement. And in order to do that, you need to have proper processes in place. And in order to scale those processes up to, it's easy to serve 10 to 50 patients for a few professionals, but how do you scale that up to 5,000 to 50,000 to 5 million? That's where technology comes in place to come and bind together with the people and process to scale these so that we can give the same experience to each person. And we could scale that, and that's what Salesforce is being known to do with retail and the big companies. To give that same experience to every single person and track it, and what can be measured cannot be improved, and have that continuous process. So I'm so excited that we're also in the space innovating with customers to drive value-based care.
Thank you. Panelists, thank you very much. Thank you for your time, and enjoy the rest of your day.